So we are going to go over a new paradigm in manual therapy, abandoning segmental motion palpation. This is an awesome article with a lot of good tidbits, a lot of review of evidence. The first part is Dr. Jam's review, and then you have editorial comments by a number of people. I'm going to hit a few of the highlights. I don't want this to be scrutinizing the details of every article, though. And at the end, I'm going to tell you how I do it. So we're going to scroll down here. He talks about, his experience of trying to feel the minutia of motion and his difficulty in doing it, and being told that eventually he'll get it. And he eventually summarized the literature, especially as it came out while he was practicing. And he notes that all studies to date have reached the same result, that which discredit the superiority of manual therapy based on motion palpation. So he's saying that if you think you need to do it a certain spot because of what you felt, that is incorrect, that the studies at least don't support that. He says that he does do it for pain detection. He notes that first, because studies do demonstrate that you can identify where the person is painful. That if I test somebody and you test somebody, that there's a good chance we agree on where it's most painful for that person. Whereas the other one, we may not agree on where they're stiff or where it's altered movement. And even if we do agree, does that mean that treating there is most important? But we can agree on where it's painful for the patient. And so then he goes over and he says he wants to assess the degree of sensitivity. This can be for a number of reasons. And he hits, second and third and even fourth are somewhat similar. Is it overall sensitive? Is it overall stiff? Is it regionally stiff? Is it stiff in just like the upper cervical, upper thoracic, mid, yada yada? Or is it just real localized, just one spot, right at the L4, L5 or something like that? And that can give them an idea as how local is it, how widespread, maybe if they have a condition that's centrally sensitized. And then the final one, he says perhaps most important reason, and I agree with this. We can go back and forth on the evidence of manual therapy and exercise and various interventions, but something that we all seem to agree on is the importance of a good physical examination, a good subjective examination, and developing therapeutic alliance. Having them believe that we are a good provider really helps no matter what interventions we're doing. And if they know that you know where their pain is at and then you tell them that they are safe to move, they will trust you much more than if you just listen to them. And you just guess based on looking at some of their intake paperwork. Touching them helps them feel like you know what is going on. So then he goes into a quiz. I'm not going to go over all the different spots on the quiz, but it's true, false. And some of these things are depending on, some of it's depending on what your background is, how important, you think these things are to fight or to confirm. And some of it hits what we've already done. But it doesn't affect only the level that you want to affect. If you're going to be manipulating a joint, whether thrust or non-thrust manipulation, it's not just going to be right there, and you may not even hit that one, but it's going to spill over into other ones. Do we need a cavitation? Here's my experience, and there isn't literature to refute this. So the literature says that you can thrust, and that if there's no pop, that there can still be benefit. And it also says that there's no difference. However, in my experience, if there is a pop to be gotten, then the patient does a little bit better. Now, is that just a placebo effect? Is that just because the patient is expecting it? I don't know. However, oftentimes when we look at literature, we're looking at for significance and minimally clinical important difference, yada yada. But if we add little bits of pieces onto our treatment every session that none of them may be significantly different, we put all that together, it can be different. So then they've compared randomly selected techniques versus specific ones that the therapist identified, and basically we don't see a difference there. That would go back to my last point, is that if you can get just a few percent difference, that's not going to show up significantly. But if you combine a lot of those, a lot of our beliefs is that that could end up playing a little bit more of a benefit for the patient. Are we going to have to be real specific with the biomechanics? I do not do this. I do not think, okay, it has to flex just this much or extend this much. I better apply this specific technique. Generally, I want to go at the as close to the spot of where there's pain or dysfunction as possible and treat there. And I don't care so much which technique. And that's where this is largely showing there as well. So now we're going to go over to specific manual therapy or exercise. And exercise shows to be just as effective. They put equally effective. Here's the thing though, when they do research, the patients know that they're being researched. There's a Hawthorne effect. I don't have the benefit of a Hawthorne effect generally in my practice. I need to have them believe me. If I can have them feel a little bit better with the manual therapy technique, then I can say, people who improve with that technique do well with this exercise. They are more likely to believe me and actually do the exercise. If they did that same exercise for a year or 6 months or whatever the time frame is for them to improve, it wouldn't matter if I had actually done that manual therapy technique in the beginning or not. And that's what the research shows. But in my experience and a lot of others, that it helps create that buy-in, that they know that you know where their pain is at, and that you have reason to believe that what you're giving them will help them. 7 and 8 are similar here. They want to know, the discussion is, does somebody need to have perfect joint mobility to not have problems? The answer is a resounding no. That being said, oftentimes if we find a stiff joint that is also painful, or they feel something there, and we improve that and they feel better, that's great. All joints, if they don't feel something or just you feel something there and they're not noticing it affect them, then maybe we don't need to worry about it. It's very likely not breaking down making long-term tissue changes. We're not breaking anything down. Some manual therapists have believed that in the past, and some I'm sure still do, and the research shows that's not true. I'm not going to comment here on the last one where it's, how many PTs believe this, yada yada. I will, so there's a number of comments by esteemed physical therapists, some of them manual therapists. Troy Seeley said, though, I agree with many of the points. However, he doesn't agree with this recent research, that the recent research says that we need to abandon segmental motion palpation, where the author seems to still go at each segment, and he's looking at pain. I look at a little bit of both, segmental and pain. So what I want to know, this is how I do it. I will look at the spine without them giving me any feedback. Then I'll ask them, okay, how do you feel A versus B? I don't say, hey, is this it? Is this the spot? A versus B. And if they feel what I feel, then I know that we're agreeing. And then to make sure that it's relevant for what they came in there for. Because nobody comes in saying, it hurts when somebody pushes on this segment. It hurts to turn their head or bend forward or sleep or something. And so if I work on that spot where they felt something and I felt something, and then their asterisk sign or their comparable sign improves, then I know it's relevant. And then I can be very confident the exercise I give them that targets that, then they're very confident of the exercise that I give them that targets that is going to help. And that's how I do it in daily practice.